I'm going to get started. Hello, everybody. I'm Angel Zadar. Today, we have a presentation that's part of our sponsor webinar series. Before we begin, I want to remind you about a couple of things. You're going to be getting emails about the annual conference. This year, it's in New York City, October 24th to 26th. It's got a great lineup. There's information on the website. It's going to be a party. It's a party in New York City. We want you to come. And I also want to talk with you about the NRBS podcast with Dr. Saul Rosenthal, one of our board members. The following the webinar, he'll do an interview with Dr. Carmen. So even more in-depth stuff after today, that will be available early next week. And you can also check out the latest podcast, which was with Dr. Fred Schaefer, who talked about the myths of breathing. Lots of good stuff in that as well. Today, please hold your questions until the end. Put them in the chat so we can sort through them and kind of like put the like questions together. Also want to let you know, Dr. Carmen is going to be able to be reached via email anytime. We'll put his email in the chat. We're not putting his website because, as he knows, I hope his website is not very informative, but you will see that he has lots of information. Today's session is recorded, so if you have to leave early, if you want to catch more of it, repeat it, that'll be available to you. It is hard to introduce Dr. Carmen without a history and a reference to Herschel Tuman, so here we go. In the mid to late 90s, Dr. Carmen wanted to work on reflex sympathetic dystrophy, and he developed an infrared system to measure vascular activity in the hand. That backfired. In fact, Jeff says it was horrible. But it verified that infrared could be used to train vascular behavior. Rather than decreasing blood flow, he was able to show it increased it. Okay, so let's talk a moment about Herschel Tuman, who was the inventor of the pIR HEG in 1994. His system increased cerebral blood flow. This knowledge led to an enduring relationship between the two inventors who really pushed each other to further development and research of each of their interests. So pIR HEG invented by Jeff, was prompted by a desire to reduce costs. And since then, he has taught hundreds of professionals, including me, in virtually every country and continues to do individual teaching via Zoom. He's the designer and developer behind the pIR HEG headset. He's published in numerous peer-reviewed journals on the topic, and he runs an ongoing listserv. He's been an ardent NRBS supporter and just a darn nice person to know. I am lucky to introduce him, who will present today on passive infrared hemoencephalography and infrared imaging of the prefrontal cortex, a synergistic combination. Please take it away, Dr. Carmen.
Thank you. It's a mouthful, isn't it?
Uh-huh.
We're going to talk about pIR HEG and infrared imaging because the two go together. Lots of people use the pIR system without the infrared imaging, but those that use it feel pretty handicapped if it's not available, myself included. So what are we dealing with here? The pIR HEG works in the frequency range of 7 to 14 microns. It's far infrared, so you can't see it. It's the range that deals with heat. So you get a lot of heat information between 7 and 14. Visible light is much shorter. Red starts around 3/4 of a micron. And near infrared is a little longer than that. It's kind of longer than 1. But 7 to 14 is where the heat is. So the system uses movies, and not as a reward. most software uses movies or clips as a reward. This uses it as an emotional stimulus. And the idea is to grab the person's limbic system and really jerk it around. And when that happens, the front of the brain goes offline. And then the person has to reverse that and kick the prefrontal system in gear and quiet the limbic system. And that goes back and forth through the whole session. So we try to actually make the person temporarily uncomfortable, which is what movie directors do for a living. They're really good at it. We don't want them like crying or running around in terror, but we want an emotional response. So I'll give you a little background. Those of you, not everybody here knows what pIR is. Biofeedback in general really kind of started out with peripheral things such as hand warming. And a long time ago, about that time, some people were experimenting with brainwaves. And actually around that time, some people were experimenting with HEG. That was Herschel, actually. But EEG is better known. A lot of people don't know what HEG is. So Herschel invented HEG. He invented the first machine in 1994. And I invented the pIR in 1998. As Angelica mentioned, I couldn't afford Herschel's system, and there were several of us in the area that wanted to work with some blood flow stuff. And it was a natural offshoot from the work I was doing with RSD, and it worked out okay. Peripheral biofeedback people think of as training the peripheral or the autonomic nervous system. But it kind of does and kind of doesn't, because you're incorporating the brain anyway. So it's hard to know exactly what it is, but it has more of a flavor of peripheral things. And more people know about it. The interesting thing about a lot of the peripheral biofeedback is that it often works for the wrong reasons. For example, with migraines, there is a time-honored tradition of warming the fingers to treat migraines. And it really works. It takes quite a while, but it does help. But it turns out that migraines don't have all that much to do with blood flow and don't have anything to do with warming the fingers. But there is some control that takes place when you warm your fingers. And it's the control system that takes control of other things, such as the brainstem generator for migraines. So it works for the wrong reasons. And that's true for a lot of things. Biofeedback cut its teeth on relaxation training. That was the tradition, train somebody to relax. And I did that for years and years and years. And I think it's not a very good idea. What happens is if you get somebody relaxed enough, the last vestige of protection goes away. There's a little bit of tension that's actually useful. And when that goes away, some people will panic. And I decided I didn't like the idea of somebody panicking in my office. But the other problem with the relaxation training is that you can't walk around relaxed. You can't walk around the streets that relaxed. You can't do anything that way. So once you leave the office, you're back up and running, and the deep relaxation remains in the office. So I don't do it anymore. So what I do is work on control systems, and that's useful for the things that are listed here: paroxysmal disorders, general management. It generally mediates things that are not behaving properly. I think of the front of the brain as a control system. Normally, people run around with it offline, and that's because of the stressfulness of our current living environments. We're more emotionally reactive than we are control and proactive. But if you can make the prefrontal cortex dominant, behaviors smooth out, and things that get out of control have more difficulty getting out of control. So here they are. At one point, neurology and neurosurgeons and neuropsychology and people that looked at specific focal points in the brain had it all nailed down nicely. And we all knew exactly what took place at every part of the brain. Not so much anymore. Now it's much more complicated. Herschel, again, brilliant guy. His comment was that the prefrontal cortex developed more recently than other parts of the brain, and consequently it would have the most software bugs. Now, whether that's true or not, you can't prove it, but it behaves like that. It screws up all the time. So it's likely it does have a lot of built-in bugs. Okay, for any of you who are farmers, and even those who are not, when you chop a chicken's head off, something unique happens. It does everything it does for a living without the head. So it does cartwheels, it even squawks. It does all kinds of things for about 45 seconds, then it keels over. And the first time I did this, my neighbor who was a farmer told me how. And I whacked the chicken's head off, and I thought I missed because the thing took off on me. And it was squawking and doing all kinds of stuff. Then I looked down and the head was there. So the chicken's head primarily is a control system that keeps other things from happening in the rest of the body. It's an inhibiting circuit. And that's what the front of our brain is. The prefrontal cortex acts towards the rest of the brain like the chicken's head does towards its body. And it's a good functional analogy. The front of the brain controls stuff. And when it's offline, parts of the brain do whatever they feel like. So we have a brain that's 50,000 years old, and adaptation to modern life is just accidental. There's nothing that exists in the modern environment for which the human brain was designed. And I think that's kind of obvious, that people have a wide variety of very strange behaviors. This guy passed away in 2015. Brilliant neurosurgeon. I based my dissertation on his concept of mental effort. And curiously enough, I've come full circle to where pIR HEG is also based on that. I view most clinical symptoms as a response that is a mismatch. And we now have tools that can modify that mismatch, but most people are just kind of designed for something else. We're designed for a primitive environment where animals want to have us for dinner. We're not designed for all this cognitive stuff. We spend days just thinking about things. So we have a variety of strange behaviors that find their way into things like the DSM. But they're really just mismatches. Now, dealing with all the emotions we deal with in our offices, some of them are incompatible with others. And this is a concept that goes way back to Wolpe's dogs. A strong emotion generally won't allow other ones. So anxiety will displace other things. It'll displace sexual arousal. And sexual arousal will displace anxiety. Aggressive behavior will displace anxiety completely. Most purposeful actions can shut down, at least in part, anxiety. And activating the prefrontal cortex shuts down most of those things. Aggression is so incompatible with anxiety that a lot of really aggressive people used to be anxious people. And at some point, they started getting angry, and the anger felt so much better that they turned into angry people. But the two are linked, they're incompatible. Depression, I don't understand. The only thing I know for sure about depression is that the alpha asymmetry stuff was probably very correct. And people who have depression, if you capture an infrared image, you get very low output over the left eye if they are left lateralized for language, which is most people. But some people are reverse lateralized, in which case it's over here. So we're not very simple people. The DSM, for those of you who use it or need to use it, is one of the most horrible books that have ever been written. The categories in here can be swapped one for the other, for the other, for the other, and they all fit. So I have this diagnosis here, and this definition actually was refined by Siegfried Affermer because mine was not as smoothly written. But excess rate and magnitude of response to relatively benign stimuli covers at least half of the DSM. It's an excessive response. And why would we have an excessive response? Because the prefrontal cortex is offline. And these are the disorders that you see related to those. Depression is unique. As I said, I don't quite understand it. I know more about how to make it better than what's wrong with it, what the pathophysiology is. We deal with paroxysmal disorders. I deal with a lot of them. Migraine headaches are a paroxysmal disorder. Seizures are, rage reactions, panic attacks. They all have more in common than not in common. And these are things that kick on fast, very strong, and then they leave. And sometimes they catch people by surprise. I don't know where the origin is. Maybe it's limbic. Sometimes it's just kindling seizure activity of unclear origin. But when you crank up the dominance of the front of the brain, the prefrontal cortex, it inhibits this stuff and makes it more difficult. So in a way, you're making the brain work against the way it was designed. Because at one time we were designed to alert very quickly and go into a sympathetic mode very quickly in order to avoid being eaten. And all that has been passed on. We still have all those mechanisms, but not usually in a situation where we're going to be killed and eaten. But we have psychological dangers. And so people perceive psychological dangers and they have these physiological survival responses. So we can think in terms of Brodmann areas, and you're kind of hanging out in this region here. With the advent of networks, this is less understandable. And understanding the brain in general is getting more complicated. Still, the prefrontal cortex remains an important area, and it's the one I think about the most. So how do we measure that? You take an infrared camera. You can do this with EEG, it just takes longer. The infrared camera has the advantage of just taking a few seconds. So you can capture information before and after every session, and it doesn't intrude into the session. Okay. What are other techniques? We have QEEGs available. They are much more detailed than infrared imaging. The only thing is it takes a while, maybe a whole session. There is also a small risk of injecting radio frequency signals while you're doing it. So it's not completely neutral. You've got wires wired onto the scalp, and signals that the wires are picking up and signals that are coming from now we call them amps. They're basically microprocessors where the wires are plugged in. So it's thought to be neutral, but it isn't exactly neutral. fMRI is the best. It provides really detailed behavioral information. It's the best, and yet it's horrible. Part of the problem, for any of you who have ever had one, they tell you about the panic button. There's various kinds of switches and buttons that you can push if you panic. And the reason is it's a very claustrophobic experience. And people are not comfortable in there. Yet it's become the standard by which the relationship between emotions and cognition are measured and tested. So think about this. You have a standard that's providing the gold standard information based on high anxiety and panic. So I have great concerns about that. It's also not entirely neutral. The MRIs that are in most clinics are 1.5 to 3 Tesla, which is the magnetic strength. Research centers can go up to 12. But as the magnetic strength increases, things that aren't supposed to be magnetic change their behaviors. Cardiac stents are considered safe up to 3 Tesla. But when you really crank it up, they could get warm and they could twist. And that may not be a really good thing. People have all kinds of metal things in their body, even if they're not ferrous metal, they can move. And things in your body that are moving, that's not necessarily a good thing. Infrared imaging, it isn't that expensive. It's not cheap, but it's just not that expensive. But it takes only seconds. So you can capture infrared images a few seconds at the beginning and the end of the session. It only sees the front of the brain, but that's where a lot of stuff goes on. Totally passive, so there's no potential of injecting a signal into the person. So this is now what I use in my office. The last one got flaky. I spent a fortune on cameras. This is one I now manufacture because I like it a lot. I call it the Carmen camera. If you look at the lens, this is the lens. That's me. The lens is reflective. It is not glass. Glass and plastic do not pass 7 to 14 micron light waves. They reflect it. These lenses are made out of germanium crystal. And they cost a fortune, and they cost way more than they should, kind of supply and demand. But they are not glass and not plastic. The only plastic that can pass infrared in this wavelength is high-density polyethylene, which is what gallon milk jugs are made out of. But everything else blocks it. A while ago, it's actually quite a while ago now, I was training people to use these things. They're little cell phone-based adapters, and they produce a really nice infrared image. And I feel really badly at training all these people because it's not that useful for repeated measures. The problem is these things are really tiny, and they generate heat with no way to get rid of it. So it alters the image. So you end up with poor repeatability pre and post and across from one session to another. So you get really nice images that you can't really make sense out of. They're really nice for checking a house for air leakage, but other than for people, not so good. So the assumptions with infrared imaging, one, that the human prefrontal cortex is important. It does a lot. That we can monitor metabolic activity. Now, HEG kind of sounds like blood flow. And at one time, both Herschel and I thought we were trying to monitor blood flow. Neither one does. Blood flow is the dependent variable. The metabolic activity is what we're after. Blood flow by itself doesn't tell you that much. The changes during a session and between sessions are what you're looking for. So the same image on 4 different people may not mean the same thing to 4 different people. But when you look at a person's image and you look at it before and after the session, and then you look at it for the baseline for session 2 and 3 and 4 and 5 and 10, you start seeing a trend. And the trend is really important. It's so important that particularly kids can tell you what it's going to look like when they come in. The trend is a really useful thing. So how do you measure validity? Numbers. I have myself over 36,000 infrared images that I've analyzed. Worldwide, we're probably looking at a couple of 100,000. They repeat each other over and over and over and over. So it's hard to validate it in an objective manner, but the correlations are repeating themselves so predictably that I think there isn't any question. So here's the energy spectrum, 7 to 14 microns. The computer will inject what's called false color because in infrared there is no color. So very low energy is down here towards black, and it goes up red, yellow, and white. There's a whole lot of different color palettes. This is the one I like. You also see a lot in consumer products advertising far infrared as therapeutic devices. Far infrared is just heat. That's all it is. It's a hot water bottle. It's a hot bath. It's laying out in the sun, although you get some UV in the sun. But it's really just heat. And so most of these far infrared devices are a mixture of marketing and hype. It's just a hot shower and anything that makes you warm is far infrared. Near infrared's different. There's no heat content to near infrared, and you see a lot of brain devices now that shoot near infrared through the skull into the brain and stimulate different activities based on the intensity and things like that. But this gets really complicated. I don't want this yet. Near infrared it's a little longer than maybe it's around 1 micron, a little shorter, maybe a little longer. But the signal itself is usually pulsed. And the pulse is typically a square wave. So you have other variables. You have the intensity of the pulse. You have the duty cycle of the pulse. You have the frequency of the pulse, which with a square wave is not one frequency. It's a bunch of it's a bunch of harmonics. You get alternate harmonics that keep going up and up and up. So when you have a near infrared signal, the near infrared signal is the one that are talked about. But you got all this other stuff that's either ignored or not talked about that may be as big a participant in the effect as the signal. And this is sort of an aside. Applying heat generally is considered to be a good thing. But if you have multiple sclerosis, it may make you worse. In fact, pre-MRI days, one of the MS diagnostic techniques was to put somebody in a hot, very warm bathtub. And if they couldn't get out, that was highly suspicious, maybe even diagnostic of MS, because in heat, people with MS tend to lose muscle control. So not everything is good for everybody. Far infrared's one of those. We talked about the pulsing. We also have a lot of electrical devices, but I only talk about this as a warning. Things like Alpha-Stem and Fisher-Wallace, they're basically TENS units that people used to put on their backs, but they go through the brain. And anytime you use earlobe clips and you're driving the signal through the brain, it's also going through the cochlea. And the cochlea is a really delicate organ. It's what you hear with. And it really wasn't designed for these voltages, which are, they are pulse signals on the order of 50 to 100 volts. It's not designed for that. So it makes me uncomfortable. I don't like to see them used. This is far infrared. It's useful for finding food for some animals and for finding people. This guy was from one of my favorite Arnold Schwarzenegger movies. And here is the way to measure whether your camera is working properly. You look at a lampshade. Why would you do that? The reason you would do that is a lampshade with an incandescent bulb is a non-living subject. You always want a non-living subject if you're testing a pIR system or an infrared camera, because people are so unreliable. You have no way of telling if what you're seeing today is what you should have seen yesterday or going to see tomorrow. So if you're testing anything that measures heat, make sure you use a non-living subject. Now here the computer injects false color, makes it a little easier to see. And so you have things that are a little more heat, which makes sense because this is higher up. And that's how you interpret the infrared image of a prefrontal cortex. So here I have some images of real people. This is a 36-year-old male with migraines. And this is my very first camera. And it was astounding and horrible. It was heavy, and weighed about 15 pounds. And the other problem is the images were terrible. This is somebody's face. If you use your imagination, the eyes are here, and this is the ethmoidal sinuses, and that's the nose. But you really have to use a little imagination. And he had these left temporal migraines, and there's more heat here in the temporal area. So how do you interpret these things? In general, low variability is associated with more normal functioning. That is, if the distance between if the intensity between the really dark areas and the really light areas is relatively narrow, the person is generally in better shape than if there's huge discrepancies. Laterality is critical. Most people are left lateralized in the brain for language. Not all. If they're reverse lateralized, all the meanings reverse as well. So this is kind of a normal image. It's got some dark, bright areas, but it's mostly normal. And this is a normal person. And here are the markers you want to look at. This area here, the ethmoidal sinuses, have a really stable heat source. And because of that, if you manage to match the ethmoidal sinuses from baseline image to baseline image to baseline image, Everything else is information. So it's a really nice mechanism. Here's another migraine. But in this case, she also has a sinus infection. And they do relate to each other because sinus infections irritate the trigeminal nerve enough to generate a migraine. And sometimes migraines generate what feels like a sinus infection. So this is a better camera. They start getting better. This was chronic occipital pain. It came and went, but it kind of never went away. Probably it was migraine. Some of these things are hard to tell. The origin of pain isn't very easy to tell. This was probably migraine. Here's a left temporal lobe, at least the temporal artery. The temporal artery often gets hot during a migraine, although it really isn't the source of the pain. Here's the end of the session. Went away. This guy was dealing with a focal pain that kind of came and went. It was always there. And the diagnosis wasn't that clear. It probably was a chronic migraine. Eventually, I got it to shut down. It took a long time. But it could have been other stuff. Sometimes it's just hard to tell. Here it is. Here and here. Got to look at this more closely. I don't remember the details on this one. I think it was ambiguous. This is less unclear. This is where the pain was. And typically, if somebody has a migraine, they're going to get pain right here and the other places, but the temporal arteries tend to be where they feel the pain, but they may not be the source, probably are not. And you can also see here that hair is opaque. Hair is a problem for passive infrared and near infrared. You can't really record through it. Same person, end of the session. Now, the sessions for migraine really train an increase in metabolic activity in the prefrontal cortex, which is counterintuitive. But it's not so counterintuitive when you think about what this part of the brain does. When you activate it, it inhibits. And when it inhibits, it quiets down this runaway stuff. This was interesting because the guy didn't come in for depression. He didn't even tell me about it at first, but he said, I've been suicidal my whole life. Left side, and he's left lateralized for language. Look at this. The end of one session. Second session, the baseline image is not as dark or as large. And the second session, here's the third. So measuring the baseline at the beginning of each session tells you a lot. It usually is generalizable to other people, but even if it's not, if you can correlate the image to the person's behaviors and symptoms, then you got it. This is a fatigue region. When you see this, the person is probably tired and also probably having trouble concentrating. This person is reversed. Language is over on this side, and that's where depression is. Same here. Now, anxiety, you see a lot of people with anxiety, as I do. It doesn't localize. It's an elusive emotion that doesn't have a clinical correlate with the infrared imaging for whatever reason. This is hard to describe. This is probably the left frontal sinus. There's probably a little sinusitis there. So this is probably all black. And an all black image generally means the person is having lousy sleep. And that may be why the anxiety was present. Not entirely, but there's the end of the first session. Big difference. Second, third, fourth. Now these sessions are one week apart. This is severe. There are complicating variables, some brain damage. But when you see these severe extremes, dark blacks with bright areas, that generally correlates with pathology. Got a lot better, but that doesn't mean it was a good thing. Autism. Did I get rid of Asperger's? We're not supposed to use the term anymore. Yep. Autism is the reverse of depression in terms of the infrared images. If a person is left lateralized for language, which most people are, autism appears in the right frontal area as a dark area. The curious thing is that after a lot of sessions, maybe 60 to 80, maybe 100, you get a light switch-like improvement in social awareness. It just all of a sudden kicks in, which means it was always there. It's very interesting. There's the end of the session. And this is a head injury. This is after a year. This guy was riding a four-wheeler without a helmet, and he drove between two trees, but it was actually double vision, so he hit the tree. So he was a mess. And by the end of the year, he was doing well. This guy was electrocuted. He had his hand touch a 270-volt line, and somehow his head touched probably the neutral, but his brain looks like this. From the MRI looks like this. I mean, it's just a mess. And by the end of the session, he didn't remember having come in, and his memory maybe was 2 or 3 minutes, and that was it. Just absolutely horrible. The bad thing about this situation, one of the horrible things, is that he was working as an electrician, but not trained as one. He was out of work, and his brother-in-law put him to work and gave him a little training, but he didn't know what he was doing. This guy got hit by an 18-wheeler, headaches, depression, focusing, and I didn't help him that much. A little. pIR is very good for rage. Rage is just another paroxysmal disorder. and it works really well. Usually it will localize over here on the opposite side from language. There's the end of the first session. It works nicely. This is anger, severe ADD, and post-concussion. One session. But she really liked Adderall a lot. And it did pretty good for her. But we were talking about, she was there and her father was there, and we were talking about her college courses for the next semester. And all of a sudden she says, "You guys are really pissing me off." I don't know what it is. One of us said, but she was mad. And I said, "Hold that thought." And I got the camera, and you can see the difference. I mean, it's just, rah! I have used this with paranoia, paranoid schizophrenia, the real deal. He was on too much medication. A psychiatrist wanted to back off some of them, so it was a cooperative venture. And it helped. It helped a lot temporarily. It never became permanent. Here's a case of mild retardation. Language on the left side, mostly dyspraxia with some dysarthria. It's very hard to tell language, expressive language, from depression. They look very similar. And you see this with attentional problems. There's after his monthly tune-up, and he became like a different person. His speech was clear and smooth, and he'd go about once a month, and then at the end of the month, he'd be in trouble again. Summary: high variability is generally not a good sign. Black areas are strongly suggestive of pathology. Reduction of variability is strongly suggestive of improved function. So I'm going to stop here. We're at 5 minutes to 1, and we now have about 20 minutes for questions. So,
Okay. Yep. I'll fire away if that's okay.
sure.
Kind of in the order, I get. Well, let me go with, people are asking about different diagnostic categories. So schizophrenia and patients with drug or alcohol addiction.
With infrared imaging?
Mhm.
Okay. Schizophrenia is not a single category. So you can't do it. The guy I had in there who was paranoid schiz, absolutely, positively, clearly. Over here with expressive language, where you'd expect Broca to be involved and stuff like that, it does show there. I don't know what that means, except that when the symptoms quiet, this area looks more normal. I don't know how to interpret exactly the meaning of what's changed, but it does show predictably on the infrared image, usually on the same side with language. And what was the other one?
Addictions.
Addictions, I have no idea.
Okay. Okay. I mean, usually addictions are, a function of something else, right? Somebody trying to self-medicate.
I don't know that that's true. I mean, addictions, sometimes you see it with people who are just adventuresome.
Well, well,
But the effect of addictions are that people's internal states change drastically when they're consuming the item or needing to consume. And so it depends on where you get them. If they're struggling and need a fix, the image is going to look a lot different, probably more highly variable. Whereas if they're comfortable, it will be less variable. And what you're actually seeing, I wasn't being facetious when I said I had no idea because it's so variable, but when the person's comfortable, there's less variability. So you think of it as a comfort factor. Go ahead. I didn't mean to tie up.
No, good, good. Since I imagine some people are going to need to leave, I'm going to go out of order of what I would usually do here. But there's a couple of questions about, are you selling your device? How do you purchase it? How do you get trained with it? How do you get the camera? All kind of the same question.
Get a hold of me.
Jeff's email is in the chat. Good.
Yeah, I sell both, but just get a hold of me. It's too complicated for this.
Okay. And then there's a couple of questions from Mitch if you want to address them yourself, Mitch, but he's asking your system, we talk about it learning to activate the frontal lobes. Would it be better controlled if the person could activate and deactivate during training? And then another one from Mitch is, how do you evaluate if people are reverse lateralized?
Okay, the first one, a lot of devices try to do that. Short of activating the limbic system, it's almost impossible. I tried to do that at first. You can activate the prefrontal cortex or you can activate something that deactivates it. But it's one of the problems is if you think about how to deactivate the prefrontal cortex, the act of thinking activates it. So it's you can't do it. And what was the second one?
The second one was about lateralization. Yeah. Okay. And I actually have something you wrote up for me on that. If I can throw that in.
Sure.
If you like.
Most people are left lateralized for language. Their brain is active on the left side for language. Most people, not all people. I think based on my cases, more brain dysfunction people are reversed than in the normal population. I see a fair amount of it. On the infrared images, if somebody's reversed, all the interpretations get backwards. So I always check for somebody's lateralization. How do you do that? Do you remember? Angelica?
Yes, it has to do with how you talk.
You have them talk, and an appropriately behaviored person would only be using one hand. If you're Italian, you might use both, and then it's really hard to tell what's going on. But if you're talking and you're using one hand to gesture with, that hand is being driven by the other side of the brain. And if that's a predictable pattern, then you're reverse lateralized for language. If they typically use a left hand, it has no correlation at all to handedness. Left hand, right hand, it doesn't matter.
Okay. Are you going to share your slides? Okay, we'll include that. Then that will be included. You'll be able to access it.
Yeah, Ronnie can let me know how. That's fine.
Yeah. Yep. Okay, and yes, I do have that write up about lateralization. I will include that. You'll be able to access that through the NRBS site. Looking good. Okay. Would a clinician need both a pIR HEG and a general infrared camera to get pre and post pictures? Okay, say it a bit.
To get the pictures, you need the camera.
Mm-hmm.
You don't need the camera to use pIR unless you have used the camera. Then it's addicting.
True. It's fun. Okay, well, with poor sleep, what's your experience when there's an underlying or systemic issue such as sleep apnea? Um, can you explain your experience? Do you see poor sleep without systemic issues?
Sure, that's a wonderful question. When you have stuff like sleep apnea, you should address the apnea before you try to address the brain. Um, there is, by the way, an experimental drug now that addresses apnea, but for the most part, you don't want to be trying to fix the person's brain if their sleep is horrible. And CPAP works quite well.
Okay. Then you talk about the question is how do you compare with QEEG brain mapping? I'm going to say how do you how do you use it maybe with EEG data and database comparisons?
The main difference is that infrared imaging is faster. There's a ton of research on behavior patterns and behavior pathology and what patterns you see with the QEEG. The thing is, it isn't that easy to make sense out of it because the QEEG is state dependent and it depends on whether the person had a good night's sleep and what they had for breakfast and what time of day it is and whether they had a fight with their spouse and on and on and on. So you get a one shot. The QEEG would be a lot better if you could do it every time you see the person. Therein lies the problem.
Yeah. We do use it as part of our initial assessment, and it just supports what we
Already know.
right. Right. Yeah. Yeah.
I mean, it's good data, but it's a one point in time, and it is heavily state dependent.
Yeah. Yeah. If you do a queue with, different states, eyes open, eyes closed in a task, at least you get a little bit different there. It gets complicated.
That's not exactly different states. If the person is like heading into a divorce or they just got a new job, I mean, those are like two extreme kinds of things. But um, the things that really affect it strongly are states that are like big time emotional states that are affecting your whole day.
And that doesn't affect the camera image?
Oh, it does,
Yeah.
but you get so many images, you can correlate the patterns with what the person tells you that day. And that's why kids can come in and say, I know what this is going to look like today. And they're always right.
Gotcha. Okay. Okay. I imagine a bunch of people had to leave looking at what I see here. I think that covers our questions. Um, oh, here we go. Yep. 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 Okay. Good comments. A lot of information. People are interested in getting the recording. That will be available. And I want to say there's a follow-up. So there's going to be more questions. Listen to the podcast. Do you have any final comments, Jeff?
Just a question on how to, I'll have to look at the size of the PowerPoint. I'm not sure how to transfer it.
We'll get that from you, and somehow we'll make sure to. Yeah, yeah, yep.
I'm good. Any other questions if you have any questions, shoot me an email.
He's fast. He gets back to them. Yeah. And I do want to say, these are webinars that are sponsored by the sponsors. Jeff is a sponsor, has been a longtime sponsor of NRBS. He's been very, very supportive. And it allows us to bring these webinars to you. It also allows us to bring the conference. So I hope you guys start looking at your calendar. Look for look what you're doing in October. It's a great time to be in New York City. So, unless if you're Jeff, who never goes to New York City. Thank you very much, everybody.
All right. This was fun. Thanks.
Take care all. Bye.
Back here, Jeff.
and all
Okay.
everyone.